Kirsten Ostherr. I am moderating but also presenting on this panel today on medical visualization technologies as tools for patient collaboration. I know that some of the other sessions are running late, so it's possible that people will be trickling in. But I think we should get started because we have 2 sessions in this room back to back, so we don't want to step on the next session's time. So the way that we're going to run this session is the 4 of us are going to present briefly, and then we will open it up for a panel discussion. But what we're going to be talking about are different elements of one project that we have all worked on together. So you will hear the different parts of it from different presenters, and they're each going to introduce themselves briefly. And can you hear okay? Is there an echo, or is it just me who's hearing that? It's fine back there? Okay. It's a little weird up here. So, okay, so I'm going to pass it to my colleague Thomas Picht to get us started. Thanks, Thomas.
Yes, thanks, Kirsten, and hello, everybody. My name is Thomas. I'm a neurosurgeon from Berlin in Germany, from the Charité Hospital. And we've been working with imaging technologies now a few years, and I would like to share some of our experiences with you guys. This is how it looked like in the beginning of neurosurgery in the 1920s. It's an image from the Brigham and Women's Hospital in Boston. So at that time, teaching surgery was very much going to surgery, where surgery is happening, and observing the one who was capable of doing it, and then trying to replicate that. These days, it looks a little bit different. This is now an image from a recent course we were teaching at the Charité Hospital together with Kirsten, and we will talk about that more in detail in the next presentations. But I think it's quite obvious here that the scenery in the OR has changed quite significantly. There are obviously much more technical gadgets, and especially many screens. And what really has changed our work, especially in the surgical field, and maybe especially in neurosurgery, is the involvement of imaging, of allowing us to image the brain in more and more detail. And where this goes now from the late 19th century with the X-ray all the way to CT and MRI implementation into clinical routine. And actually, each of these evolutionary steps in imaging was awarded with a Nobel Prize. So these have been really important steps. And well, the last, in the lower row, you see the CT image and the MRI images, and these are digital images. And this then again allows us, and you see that in this lower right image here, to reconstruct the sliced images into 3D objects. So 3D object of your patient's brain. And this has really revolutionized our treatment planning and also our treatment performance, and I will show you an example of that. You see on the left side here, this is what you might be a little bit familiar with. This is an MRI scan of a brain. And you see a brain tumor right here. And this reconstruction here is based on this MRI scan. So it's a 3D volume. You see the tumor there in red. You see these fibers running around the tumors, which are very essential for function, so these need to be preserved. And in the next image here, it's exactly the same raw data set, the same MRI, with a different software post-processed, and it looks very different. It's still the same case. And another example here. And the point I'm trying to make here is that depending on the software you use these days, the way of you represent then the disease is very different. It's all based on the same MRI data set. And then you can also take it a step further and not only look at on a 2D screen at these reconstructions of your patient's brain, but also with 3D stereoscopic goggles and have the 3D depth perception then. And you can see that here, that was also part of this teaching course. Well, all this, what I said until now is showing you that this kind of imaging technology has really changed the way we can beforehand look into the brain. But the question, of course, is how does that affect our treatment of our patients? And what you see here, that's probably out of the patient's perspective, the most important step. This is when he's signing the consent to allow us as surgeons to perform surgery, in this case to open his skull and try to take out a brain tumor. And signing the informed consent means we have to inform our patients in the best possible way. And typically, the patients are not so interested in every really detail in the MRI image, which we have to be interested in to perform the surgery safely, but they have more basic questions of understanding our rationale, why to operate to begin with. And one way you can use these images, these MRI images, is that you perform examinations image-guided. And what you see here is an examination which allows us to stimulate the brain non-invasively before surgery to understand where what function is. And after doing that, we have experienced that it's extremely helpful to take the patient immediately after he has underwent this examination in front of the screen and explain the image to him. And then you can make the connection between the function which you just experienced, for example, when you stimulate motor areas that the finger is moving, and the brain area which is responsible for this function, for this neurological function. The next step then, of course, is to use these data in the operating theater. And these days, usually these brain tumor surgeries are done with neuronavigation. So we again use then the MRI data to guide our craniotomy planning, so where we access the tumor, and then also during surgery to find the tumor and to spare the essential parts of the brain and just take out the tumor and do not harm the patient. And again, you see here, this is now again a recent image from our OR. There are a lot of screens. The most recent developments are that we not only use the microscope and see the brain in very much detail, the magnification is in the range of 50 times, but also that we augment the reality with additional data. So what you see here, that's the microscopic view of the brain surface. And then here in augmented reality, so kind of mixed reality, the tumor is injected into the surgeon's view. So you know where it is. It's in the depths, but you already know when you open up that this is the way to go. So this helps us to perform safer surgery. The next step now is, which is on the doorsteps and probably going to be implemented more and more in the coming years, is that we are getting rid of the microscope. The problem with the microscope is that as surgeons we have to be fixed in this position to look into the oculars for hours. And the next step now is to use the microscope just as a camera. You see the microscope up here, and to use 3D, 4K, high-resolution screens to perform surgery without being restricted to looking through the ocular of the microscope. Well, this is already my last slide. To pass over to my colleague Anna, just a quick note on how this technology affects our treatment and also the patients. It seems to be kind of an assumption that the more technology you use, the better your surgery is and the better your patient treatment. But this is not necessarily the case, and with this I would like to pass over to Anna.
Thank you, Thomas. I will also briefly introduce myself. My name is Anna Roethe. I have a double background in medicine and culture studies, and I work together with Thomas and Rebekka now for over 3 years. And what we did in the beginning when we decided to conceptualize a teaching curriculum for medical students was that we asked ourselves how to respond to these imminent, prominent, very important technological changes we are facing, especially in neurosurgery, but not limited to neurosurgery in recent years. And how can we incorporate that in med school curricula? How can we prepare even an implementation of these aspects, contents, technological trainings in continuing medical education? And how can we actually prove what is needed and how it should be conveyed to doctors? So what we did was, in the first description of our course we are now teaching for over a year, was to put the main objectives out there, which basically are, so I'm just going to read this out. The first general objective of the module is to sensitize students to the extraordinary significance of the image in modern medicine, and particularly in surgery. The second general objective of the module is to empower future doctors to apply medical imaging in the best interest of their patients. Very important, and Thomas already hinted at that. The third objective underpinning the module alongside the fundamental teaching of image analysis is the mediation of current technical developments in the field of medical imaging, something which must be continuously updated. And that's also a problem for us, and it has been addressed in several sessions so far during this conference, that a lot of new technology that actually needs clinical evaluation, feedback from patients, integration of more stakeholders than have been involved before, is too fast evolving to actually be part of clinical randomized trials or any other kind of clinical validation. So that's really a problem. Once you finish an RCT, the next iteration of the technology is already on the market, or even the next. So that's also a problem for us, because once we decide to teach something in med school, like the Da Vinci robot, for example, which is used in general surgery in Germany for, mostly, it's actually an old technology. So the new stuff, also in robotic surgery, actually needs to be directly transferred into med school and discussed in terms of benefits and shortcomings. So back to our curriculum, we decided to have 3 major parts of the course. It's a 2-week elective at the moment, which is taught in the hospital mostly. We have theory, input, and discussion. We have hands-on sessions. We have on-site visits for 20 students per course. The main topics that are addressed during the curriculum are media history and medical image evolution, very important, diagnosis and patient consultation, new technology experience, and clinical imaging in changing parts. And we continuously adjust that according to the students' feedback we get on the course. In the theory discussion aspects, we address primarily art history in medicine, surgical image worlds from 19th to 21st century, patient communication, technological discourse, which actually serves as a form of preparation for standardized patient interviews for the students, diagnosis and treatment information, functional mapping techniques, very important in neurosurgery, intraoperative imaging, also very important, AR, VR, which is trending but also interesting in the educational setting, because students give different feedbacks on implementing those technologies than professionals do, which have been in the hospital for maybe 20 years and have a different perspective. Then intraoperative functional guidance, the CyberKnife technology, I don't know if you're familiar with that, which is basically a radiosurgery device which has been on the market for quite some time, and I think it comes from Stanford originally. The future OR, which also is a hot topic at the moment, for many disciplines involved in the discussion, how should the future OR look like? And also imaging techniques, differences, similarities in neurosurgery and neuroradiology, and basically all neuro disciplines. For the hands-on part, we focus on 3D vision and 2D media, which also means, and my colleague Rebekka will get more into that, that we let the students draw and experience different softwares. NTMS mapping, which is a non-invasive mapping technology for patients with allograft brain tumors to identify very important brain areas. Pre-surgical planning, including software interaction, again, AR, VR, so the students get to explore different devices from different companies, different softwares, custom-made, all kinds of stuff. And standardized patient interviews, and lastly, the on-site visit mainly encompass OR visits for different kinds of procedures, and again, the CyberKnife. And as you probably already have seen, all of these activities, topics need a broad perspective, a broad range of expertise, speaking to each other, listening to each other, and discussing things from different perspectives, which means, and in our case, that's absolutely true, because we started as a research collective, and now we're a teaching collective, that we have a lot of disciplines and specialties participating, which is neurosurgery, neuroradiology, culture and media studies, public health, interaction design, art history, and visual communication and design. And it means, and we cannot stress that enough, that this multi-perspective and problem-oriented input is very important for the whole discussion. And the feedback we get from the students so far is amazing.
Thank you, Anna. Hi, everybody. My name is Rebekka Lauer. I'm the interaction designer on this former research now teaching project. And I want to start with this. Before a patient communication can be processed properly and really patient-oriented, the doctors have to get to know their tools, the imaging, all the medical skills they need. And nowadays, they are usually trained in reading the imaging, the sectional images, the medical images, but they are usually not so much trained in interacting with all those softwares which are displaying those images, which are, which they need to get to know the content of the images and the, So what I did, still on? Yes, okay. What I did in the research, from a research project, is a huge design research on the clinical side, and out of that out of those observations, I took 3 points which I want to stress here, which I think, or we all together decided to be important enough to work on with the students. The first thing which occurred is that images are coming on very different, huge variety of display media. If they are in-house images, they are coming via PACS views, which most of them are really common with, but then you have also, if they are outpatient patients or ambulance services, the patients coming as well with those printouts sometimes, or with data on DVDs, and one day I saw 3 different DVD reader softwares plopping up on the screens, which totally distract the surgeon or the physician from the patient interaction in the ambulances, because he was always struggling and knew how to interact with those interfaces. Second was that the knowledge which is then applied in the OR setting is mostly tactile and embodied knowledge on the surgeon's side, and should be supported by the visual media. But as it turned out, there are lots of hurdles in there, and which is, So what is important is that we need to focus or to take into account that cognitive abilities and the focused textile experience is really key for the surgeons, or for the future surgeons. And this is why we came up with this kind of design-driven exercises we put in the hands-on part Anna introduced previously. And due to the time, I've decided to just go into the sketching modules, which are picking on the 3 points I introduced before, and then show you how we build up everything accordingly. So the first session we do is the sketching 1 session. It's addressing the visual literacy of reading 3D visualizations on 2D media, which we do by introducing the students to perspective drawings or perspectival sketching rules. And they first start to do landscapes in different perspectives, just to get a mental image of how those things then, or the 3D objects, can be projected on a 2D media. Then we proceed with sketching cubes on paper, and turning them around to make them able, or to introduce them to them that they can cognitively twist the objects, and to get a little flexibility within their inner abilities of visualization. And then the third thing is we are ending up with more freehand, but all still constructive rules of how to have circles and spheres within those cubes, which is then later needed. You will see this in a second. As a second step, we employ models to translate the concept of sectional images, which is what you see down here is the cube model. We show them for sketching, which is the outline thing they then should reproduce on the paper. And we had the last time this model, which is kind of a sectional imaging module, rebuilt in a 3D mode just to make them really graspable for the students, how those images on the software are connected physically or mentally, cognitively. What they need to do. And what we already decided to do, and this is why I put it already in here, is to have them building on the workshop site their own blank white layer model to bring then to the next session, which is the pre-planning, hands-on surgical pre-planning session where they are introduced a case, a patient case by Thomas to them, and they were handed out the sectional images as printouts and some functional data as well, and then they should try to sketch as best they can what they think is the pathology and the spatial relation between the tumor and functional points and so on, just to see, or for them to experience how hands are able, or how strong the hand-brain connection is for understanding and really getting to know the positioning. And I think this is where I just want to end, is that it's true, for sure we don't want to make them being an artist or a designer. It's not possible in only a few hours, but what we want them to see is that their ability to strengthen their ability to rely on the personal, their embodied knowledge, and as well on how strong the relationship between hand and brain interaction is. And with that, I think I will hand over to Kirsten again.
Thank you, Rebekka, and thank you to Thomas and Anna. And for those of you who might have just come in while this was happening, just to catch you up, we're describing a collaboration that we've been doing together at the medical school in Berlin, where they are all based. I am based in Houston. And we're talking about the roles of neurosurgeons and scholars of cultural studies of media and interaction designers and others in collectively helping students understand the role of complex imaging modalities as communication tools and with patients. So the way that I came to this, I'm not an MD, but I've been studying visual representations and their role in shaping how doctors and patients see and understand health and disease for a long time. At Rice, I created something with my collaborator, Brian Vardabedian, called the Medical Futures Lab, where we explored these topics at the intersection of humanity and technology through hands-on, collaborative, participatory design projects, which we've been doing for a bunch of years. And really, we do this thing called the Medical Media Arts Lab, where we really seek to intervene in the ways that anyone in the health professions uses and understands the role of media and other kinds of visualization technologies in the ways that they approach healthcare. From whichever vantage point they may be taking on that. So I've been involved in teaching this course with my collaborators now. Twice we've done that this year. And I just wanted to kind of bring in, for your perspective, some of the things that I was teaching about in there, which had to do not only with visualization technologies, but really bringing in the e-patient perspective, which is something that I've learned a lot about at Medicine X over the years and have been teaching my own students about at Rice. And so one of the things we did was assigned a bunch of readings to the students there to kind of bring some of the stuff that that people are working on in terms of patients as collaborators and participants in research into the dialogue there. So this is just a sampling of some of those readings, and if anyone wants to ask me for the list, I'm happy to send it to you afterwards. But if you just scan the list of authors, you can see a number of people who have presented at Medicine X in the past and who are kind of active contributors to the e-patient community. I also showed them a couple of videos of Medicine X e-patients. Emily is here. I told her yesterday that we had been using her video, and she was very delighted to hear that. And then also Sean Ahrens has presented here in the past a number of times. So we showed videos by both of them. And these were some of the learning objectives that we were trying to get the students to gain out of their interaction with these readings and videos and the other kinds of lectures and things that we did in the classroom. So as you can see, a lot of it is about getting them to think differently about the relationship between doctor, patient, and technology, and to try to reframe their thinking about what communication means and how they might approach that differently given the digital tools that are at their disposal, but also given the challenges and opportunities of working with a lot of imagery in medical settings, as they do, especially in neurosurgery, but in other fields as well. So the last thing I just want to describe to you before we open it up for a panel discussion and for questions is that we had the students do some writing because we wanted to kind of see how they were processing. You know, we had discussions. It wasn't just sort of standing around and lecturing, but we wanted to see when they reflected on what they had been learning so far, what they actually got out of it. And that was also one of the objectives of the class, was to get the students, the participants, to understand that conscious reflection on the practices that they were engaging in their medical practices was a really critical part of learning to use these technologies differently and better. So not just learning how to use them, but thinking about how they were doing so and being able to kind of verbalize that was really important. So we gave them this writing assignment to address this question: what is the role of technology in patient care, and how do imaging technologies mediate the doctor-patient relationship? And we asked them to write just a short piece, 500 words, about it. And I just pulled out a few sample quotations that I wanted to read to you that I think really captured some of the responses that we got. So in this one of these students said that using all these technologies can lead to the illusion that we can reach absolute certainty in every case, and that was one of the topics that we were really intent on discussing with them, was the ways that technologies can make it seem like you can actually see everything, but in fact there's a lot of interpretation involved, and you can really see that with the work that Rebekka was having them do from the point of view of designers. So then this student goes on to say, we talked about the role of 3D models of tumor patients' brains, what role that could play in doctor-patient communication, but if I imagine myself having a brain tumor, there would be thousands of other issues more important than seeing the definite location and size of the tumor in my head. So I was really interested in this as an example of the way that students were thinking about how these imaging modalities could be communication tools, but they also needed to lead to communication about things that might not really be in the image. Like things about, like, how is this going to impact my life? Am I going to live? What's going to happen to me? Here was another quote from a student that I thought was very revealing. This one said, trust in technology, as well as trust in the ability of doctors and patients, is fundamental in healthcare. New technologies can enhance or diminish the interpersonal relationship between doctor and patient. And this is key, and it's not something that is often explicitly reflected upon, but as we bring new technologies into doctor-patient interactions, we have to really think consciously about how they're actually changing that interaction. They don't automatically improve it, as Tomas was saying earlier. So this trust needs to be built and renewed constantly. So every new iteration of new technologies, it's easy, in the way that you were saying, Anna, to kind of just race to keep up without ever kind of pausing and reflecting on the reality that they are having a really serious impact on what is ultimately a human relationship, and that needs to be kind of addressed explicitly in medical training as well as in doctor-patient communication. And the last one that I wanted to read to you, so we did talk a lot about imaging in this class. It was all about visual imaging technologies. So this student said, all in all, imaging takes a special role in the modern doctor-patient relationship, aligning the two parties and contributing to empowerment, not only of the patient, but also of the doctor. What matters is that images alone don't make a story, and despite improving technology, patient narratives are still the completing factors for good disease management. And I really love this one because it kind of, that's what we wanted them to get out of the course, actually. So I think we were all very pleased that, that this student kind of put it into words so concisely. We were really trying to get them to think about the relationship between technology, very high, so you saw some images of very high-tech kind of modalities that you might have in tumor surgeries, but that also what they really need to understand is how to balance that with communicating with patients, with listening to patients, with hearing their stories, and with using the story to frame the role of the technology in the dialogue. So with that, I would like to open it up to questions from the room. I have a bunch of questions for the panel as well, but I'd like to open it up to you first in case anyone has anything they would like to ask at this time. Any questions? Okay, well, perhaps while people, did you have one? Yeah? Okay.
Yeah, that's that's a very good question, and the time constraints are a huge problem, obviously. And on the other hand, the surgeons are expected to learn the trade faster and faster to be able to be independent in the OR and make money for the hospital. So that's kind of a difficult situation, and we think that that's also why we start in med school now, to prepare them to use these new modalities to the best possible way, in the best possible way. And although we are also but we are also skeptical about these visionary scenarios of the future, how the OR might look like, because in the end, we're still taking the tumor out with our hands. But there are definitely great opportunities to improve teaching. The first two slides I showed, or images with people observing what the surgeon is doing, I mean, that takes then years before you really understand what's going on. If you transfer the same situation into a virtual reality environment, for example, we hope that this will speed up the process of learning the trade of surgery in the long run.
Can I add briefly something to that? What really helped us was talking to surgeons who were in one way or another unhappy or unsatisfied with the current workflow. And if you reach the point where you get them to voice their concerns, their unhappiness, the impact on the team management, that there's no debriefing, that maybe, I don't know, their economical efficiency goes down, operating times increase, and the company training is perceived as insufficient. And we had, I mean, even in Berlin, we have a lot of official company training for the surgeons. No one is showing up. And the company claims this is the way to go, and why should we alter anything in our strategy? And the surgeons are like, well, company won't listen to us. So there are different pushes in different directions. And once the surgeon face their own concerns, their own dissatisfaction, they're actually willing to listen. And as soon as you can prove them step by step that it's helping to invest maybe 5 to 10 minutes, but get something out of that, like finally understanding how the technology basically works, so get a basic understanding what it can do, what it can't, that definitely helps. And we did that, and now we get better and better feedback, and the surgeons are also more willing to invest more time into small workshops to evaluate new technology and to spend time to learn it, and also give feedback on how it could be even improved for surgical training.
No, there's another. Oh, yes, yes, please.
That's good. Yeah, so the idea was to ultimately improve surgical training because we see a big demand over there, but start early and explore the methods, start early, make the students familiar with the technology, give them something to think until they return to the surgical training, and also open their minds to, outside perspectives, so-called, because we don't think that actually interaction design is an outside perspective in a world where you have technology designed for an OR environment where all those stakeholders need to talk to each other, which involves not only biomedical engineers, but also designers, and of course, surgeons. And that's how we kind of started to include that into med school, maybe moving on from an elective to mandatory courses and then taking the next step to CME. But we have smaller events which we conduct with surgeons and consultants. Yeah. Kirsten.
I don't know of a course quite like this being taught anywhere in the United States. It's possible that it is, and I just don't know about it. But our collaboration has also emerged from, in part, stuff that I've been doing with colleagues in Houston as well, where oftentimes we teach pre-meds and med students, but every time we do presentations on this, we have doctors who ask the same question you asked and who then say, you know, because I would like to take this course, basically. And that's why, yeah. Mm-hmm. Mm-hmm. I think that this, we are at the beginning. I mean, I don't mean us uniquely. I just mean that in, you know, worldwide, like we are collectively at the beginning of bringing this kind of training into medical education and continuing medical education. So I think there are experiments happening in different parts of the world, and there's a growing sense of the importance and a concurrent dwindling resistance. But there's a kind of balance there that has to, that's tipping. Sorry? Would the doctors like to speak to that? And then we'll open it up for any other questions as well. Resistance, that is, in medical, to changing medical training.
Well, it's still extremely traditional. The curriculum in Germany in med school is not touching on these things more or less at all. I mean, it's changing slowly, but way too slow to keep up with the development of technology. And so there's definitely a need to do that. And coming back to your question also, who is taught in this course? Most of the students who sign up for this course probably have on their mind to maybe become a surgeon, maybe a neurosurgeon. So there's kind of a pre-selection. And something we also think could be a product of this course is to enable the students also to make up their mind, do I have the right talent for this profession, or should I go to maybe a non-surgical profession? Once you make this decision and start your residency, it's seldom that people drop out again, although they might realize, I'm not really good in 3D orientation, for example. And to know that beforehand would really help, yeah.
And also, coming back to the aspect of patient communication, what's very important for us, and I think that's also uncovered land out there, is moving beyond company advertisements for new technology, promising a lot of improvements for patient care without actually proving it or going into detail. And what we saw in Germany was that a lot of patients during patient seminars got back to us asking, why should the patient take a course to learn what technology can do or cannot do? Why should we learn where to search for valid information on treatment success and technology support? Why don't the doctors take courses to learn how to tell us what technology is capable to do and how it has to be designed in order to help us, and when is technology maybe not the way to go for me in my specific condition, because that's usually not covered by public discourse.
Yeah, it does definitely make sense, yes. But it's difficult to answer. I think there's a risk, maybe we could say, that the next generation of doctors takes everything which the image shows for granted and relies too much on the images, for example, so that an image-guided surgery, it cannot be done by a robot. You still have your underlying knowledge of anatomy and how it should be done, which is then supported by the image guidance. But I see kind of a risk in the younger colleagues that they think what the computer tells me is 100% true without knowing what the underlying software has done to the raw data, for example. When the MRI is post-processed, like I showed you, it's not the real thing anymore. There's a difference between the virtual patient and the real patient, and to raise awareness for that is one goal of our course.
And doctors and patients alike tend to take the image as the ultimate truth.
Yeah.
We have 2 more minutes before we switch panels in here. Does anyone have a final question? I wanted to just ask, in case anyone in the room is contemplating trying to launch a course like this, what do you all think, is there a piece of advice you would give to people in terms of, we could do a whole other session on the challenges and kind of the things that we've all learned from working with other people with different kinds of specialties in this sort of collaboration, but is there a piece of advice or a kind of insight that you would like to convey to the room before we close? Rebekka?
Yeah, that's what advice? I think from my perspective as an interaction designer on the whole medical or neurosurgical field and on the future tasks of neurosurgeons, is that I think there's a huge topic in the whole field which I see not enough discussed, and there's no awareness for is this what I mentioned, tactile and embodied knowledge. So everything is learned just by brains and rationality, and nothing is, they are deeply relying on figuring out how the feedback of tissues to decide, for example, which kind of resection tool they are taking to take the tumor out, and so on. And this is a part there that tactiles and the haptics is not really trained. As for my understanding of the situation, I am a product designer. I always was, I always had to work with form and other kind of materialities to see, and there's a richness in my experience on different behavior and so on, and this made me, being so convinced that this would be help medical students to prepare, even though it's not a human tissue in the end, but they are just learning by different inputs on their tactiles.
Quick closing note, and we'll
Yeah, and
wrap it up.
also about involving all these different disciplines. You have to keep in mind that it's not enough to have all those people in the room and just let them talk. You have to communicate, and you also have to be aware that for facing challenges like this one, and we could have a lot of similar examples in the medical field, not just the neurosurgery, you need to develop new forms of expertise, and you need to do that together in exchange. So it's not enough to be a neurosurgeon, stay a neurosurgeon, and say, I have an interaction design and the room problem solved. But both need to move on and have a deeper understanding what the methods are, what the opinions are, what the shortcomings are, and become new forms of experts.
Thank you very much. Please join me in thanking the rest of the panel.